This summer, I was fortunate to be an intern at the Columbia University World Health Organization Center for Global Mental Health, working under my research mentor, Dr. Kate Lavero, on her project, Assessing Trauma Among Adolescents in Mozambique. The first question to address is, what is global mental health? Global mental health is a commitment to improving mental health worldwide, which usually looks like a process of identifying gaps in resources, knowledge, and implementation, and filling those gaps with evidence-based solutions. In the case of Mozambique, the gaps in resources identified have been in mental health care professionals. For example, the rate of psychiatrists in Mozambique is 0.05 for every 100,000 people, which equates to one psychiatrist per 2 million people. In a country of 28 million, only 387 governmental and non-governmental mental health professionals exist. So what do you do when faced with these personnel shortages? In global mental health, you can employ task sharing and scalable interventions. Task sharing involves integrating mental health care into other areas of care, such as primary care, general health care, and even places of worship. Sharing these tasks with untrained mental health professionals usually requires training, which is where scalable interventions comes in, which are condensed versions of evidence-based treatment, which can be administered by non-mental health professionals. So my mentor's project specifically was mental disorder assessment in Mozambican adolescents, for which she and her team traveled to Maputo City and collected data from 2 schools on trauma experiences and depression faced by the adolescents in those schools. And the overall aim of the project was to investigate how best to integrate mental health services for adolescents into primary care, which requires an understanding of how to identify and how to treat pathology in this population. So table 1 shows the results from the child PTSD symptom scale, which was used to assess trauma in the participants. And though the findings on their own are interesting, especially for understanding common trauma experiences in this population, more contextualization is needed from past studies, and a useful grouping for these trauma experiences would allow for cross-comparison with other studies, which is where I came in. So after conducting a literature review and extensive research, I recommended 3 ways to group the traumatic experiences from the previous page. One way was by number, which would be asking how many participants endorsed a certain number of events. Another way is by type, which would be how many participants endorsed events belonging to a certain category of traumatic event. And the third way would be polyvictimization, which is the presence of multiple types of victimization. So how many participants endorsed certain numbers of types of trauma, which would be, for example, endorsing both sexual and physical violence. Here's the data for grouping trauma by type. I developed these categories, modeling them after the PTSD criteria from the DSM-5. And as shown, witnessing physical violence was the most prevalent type of trauma in this population. And here's the data from grouping the trauma by number of types of trauma endorsed. And as shown, 36.5% of participants endorsed more than one type of trauma. So in this study's definition of polyvictimization, that 36.5% would be considered polyvictims. Why group trauma in different ways? Well, the analysis of different groupings of trauma yields different relationships with psychiatric outcomes. For example, with the number of traumatic events, past literature reveals that there is a dose-effect relationship. Um, so increasing the number of traumatic events usually results in an increase in trauma symptoms. Also, polyvictimization has been shown to lead to more negative mental health outcomes. So a greater number of type of events endorsed yields more negative mental health outcomes. We expect to find similar results in this study, and analysis is in progress. So why is this important and why is this cool? Well, this is one of few studies to focus on trauma symptoms in non-war affected in a non-war affected adolescent population in the lower and middle income countries. Typically, studies of this type in lower and middle income countries focus on war affected populations. And also, this study gives us better insight and a better cultural understanding of trauma among this population, which yields better treatment, which is at the heart of global mental health. Finally, I'd like to thank my research mentor, Dr. Kate Lavero, the Global Mental Health Program, and the Center for Health and Wellbeing for funding this research.